Good morning, all. This is Dr. Manuel, the scientific chairperson. We will wait for another 2-3 minutes more. So once we have around 40 participants online, we'll start with the program. Thank you so much for waiting patiently. Good morning, everyone. This here is Dr. Manuel. I am the scientific chairperson. So I welcome you all. So we'll get started with our event. So I would request you all participants to keep to unmute, and if any queries are there during the program, you can post it in the chat box in the Zoom link, in the Zoom chat box, and if time permits, we will answer those queries and we'll have a discussion. So I invite Dr. Rupesh. He is an EC member of ISPRP, and he is actually the previous scientific chairperson. So he is the one who actually initiated this online webinar, which even we are continuing even now. It's a monthly affair. Every fourth Sunday we have this event. So next time onwards, please log in on fourth Sunday every month. 10:30 to 11:30 is this online webinar. So I invite Dr. Rupesh to welcome the gathering.
Thank you, Manuel. A very good morning to each and every one of you. Dr. Gopichander, President of the ISPRP, the Dynamic Secretary of ISPRP, Dr. Vipar Shetty, Treasurer Dr. Paras, immediate past President, a good friend of mine, Dr. Anil, President-elect Dr. Mahalakshmi, Vice Presidents, my dear friends, Dr. Bennett, Dr. Rajkumar, Editor, Dr. P.S.G. Prakash, the Dynamic Gentleman, the Joint Secretary, again, a good friend of mine, Dr. Anita, Scientific Chairman, the man who just saw, who gets all these things going meticulously. Dr. Manuel Thomas, Membership Committee Chair, Dr. Shruti, Dr. Brinda, the Networking Chairman, who is making ISPRP popular globally. A big warm welcome from the ISPRP office bearers to all those who have logged in from far and wide. Friends, today we have a very dynamic and interesting speaker who's going to speak to us on a very pertinent topic, especially of importance for us here at ISPRP. And literally a man who is probably burning the midnight's oil, as it said, literally, all the way from Iowa in the USA, who I think the clock has just tipped over to midnight in the US, in Iowa. We have with us Dr. Abhishek Parolia, who is the Assistant Professor of Endodontics at the Iowa College of Dentistry. Let us all together accord a big warm welcome for this gentleman who has taken his time off and who has agreed to be with us here. Friends, multidisciplinary and interdisciplinary is the core and essence of what ISPRP is all about. And today's topic, dental practice management, a multi-directional approach in patient care, I'm sure is a topic which is in that particular direction. And I'm sure all of you who are here to listen to him will take home a lot of brownie points. And probably today, those who are listening will probably press in the caps lock button and make all the points what Abhishek is going to speak to us in etch in your mind, in bold, in caps lock, not because today is National Caps Lock Day. I don't know how many of you know that. And when you look at Dr. Abhishek, you can see that he's a very colorful personality. And I'm sure this talk today also is going to be a very colorful affair. And it is National Colors Day in the USA. I'm not too sure if Abhishek knew about it. Today is National Colors Day. And all of the audience who are married, it's very important to note that today is International Mother-in-Law's Day. So make the mother-in-laws happy. Today happens to be that particular day. And very importantly, today, the 22nd of October, is International Stutter Awareness Day. Stutter awareness. So like Manuel said, all those who have gathered here, all the postgraduates who probably have gathered here in big numbers, please don't stutter in asking your questions, whatever doubts you have in mind, whether it is this webinar or anything else. Never stutter in asking questions which is creeping into your mind. So even today, if you have such questions, kindly do post it on the chat box. Before I move over and before we invite the moderator to come in and Dr. Abhishek to speak, there are a couple of points I'd like you to make. I want you to know that we have our first ever ISPRP national level UG convention, which is coming up at the prestigious SRM Dental College at Chennai, Ramapuram, Chennai. So I request all the heads of departments, all the postgraduates who have gathered here, all the faculty who have gathered here to kindly percolate this message to your other faculty members who are there in your institute, and see that a large number of undergraduate students register for this first ever magnificent event that we're going to have on the 15th and 16th of December, that is. There'll be a lot of lectures from eminent speakers, video demonstrations, cutting edge technology, which your undergraduate students, I'm sure, will be exposed from all the three specialities that ISPRP is all about. There are plenty of poster and paper presentation opportunities for your students, quiz competitions, table clinics, and to make matters easy for all of you through popular demand, the ISPRP head office and the organizing committee has extended the early bird offer to October 31st. So make use of this opportunity. The registrations, as you can see, are very barely minimal, which will benefit all your undergraduate students. And also for the benefit of the students, the organizing committee has also extended the abstract submission date till the 15th of November. So this is one information I need to pass through. I'm sure all the heads of departments also have been sent in a flyer regarding the undergraduate and PG Excellence Award for the ISPRP. So Dr. Anita would have probably sent all the mails to all heads of departments. So please submit those submissions also. That will be a great recognition for your UG and PG students. There is one more very important thing, which our dynamic editor, Dr. P.S.C. Prakash, has asked me to convey to all of you. Unfortunately, he couldn't be here today because he's on call of duty in his office. This is with regards to the Journal of Interdisciplinary Dentistry, the only interdisciplinary journal probably in the country, which addresses all the three specialities together. The Journal of Interdisciplinary Dentistry. It calls for original research and case reports and systematic reviews and meta-analysis paper. Only thing is that all has to be of the three specialties and interdisciplinary in nature. We are also extremely happy to inform you that we are now indexed by the UGC CARE, which means that this would be recognized. All the articles you are submitting would be recognized by all NAC affiliated universities. So your article submissions to JID would be recognized by all NAC affiliated universities. And very soon we are planning for the Scopus indexing probably by the end of this year. So Dr. Prakash requests all your support and encouragement in taking our journal forward. With these few words, let me once again welcome each and every one of you, especially the man from Iowa, the man who probably is having an Hawkeye. Iowa is called the Hawkeye state, if I'm not wrong. So Abhishek, once again, a big warm welcome, and over to you, man.
Thank you.
Before Abhishek takes the stage, let me just introduce to you our the moderators for this webinar. I hope I'm audible. Just one second. So one of the moderators also gave the welcome address. So Dr. Rupesh, I've already told him he was the past scientific chairperson of ISPRP. So I'm happy that sir could join us. So he is a professor and chair at Coorg Institute of Dental Sciences, Virajpet, Coorg. And he completed his MDS in prosthodontics in 94 with a total teaching experience of 24 years and over 24 years. And BDS in 1991, he did from Mangalore University. And as I've already mentioned, he is the one who actually initiated this online webinar, which is benefiting a lot of postgraduates. And next we have Dr. David. He is a periodontist working at Manipal College of Dental Sciences in Mangalore. And he did his BDS from Christian Dental College, Ludhiana, Punjab, and his MDS from MCOTS, Manipal. So I welcome both of you, our moderators, for sparing your time on a Sunday morning. So next we have, let Dr. David introduce the speaker, Dr. Abhishek, and then we'll start with our program.
Good morning. Good morning, everyone. It gives me great pleasure to introduce our speaker for today, Dr. Abhishek Parolia. Dr. Abhishek did his BDS and MDS endodontics Manipal and MFDS RCPS Glasgow, MFDS RCS Edinburgh, and PhD from Malaysia. He is currently working as an associate professor in the Department of Endodontics, University of Iowa College of Dentistry and Dental Clinics, Iowa, USA. He has been the associate dean for postgraduate continuing education and research in International Medical University, Malaysia. He graduated from Manipal University and was awarded a gold medal in conservative dentistry and endodontics. His professional accomplishments include Research Incentive Awards in 2010 and 2011 from Manipal University, Best Newcomer in 2011, awards for invaluable contribution in leading ICDAS initiative in 2014, E-Learning Innovation Award, and Best Lecturer nomination in 2016 from International Medical University. He was awarded the Best Faculty Presentation Education Research Group in 2017 in International Association of Dental Research, San Francisco, USA. He has also been awarded for developing a new postgraduate program in endodontics and for his long service in 2022 by International Medical University, Malaysia. He has received the Teaching Innovation Award team category in AMEE Glasgow 2023. He is a member of the American Association of Endodontists, International Association of Dental Research, Royal College of Physicians and Surgeons of Glasgow, and Royal College of Surgeons of Edinburgh. He has secured grants worth a total of 1 lakh USD as a principal and co-investigator and published more than 80 scientific papers in peer-reviewed journals and has authored 5 chapters in different textbooks. He has conducted hands-on workshops in various countries and lectures in various countries, namely USA, Singapore, Brazil, Hong Kong, Dubai, India, Malaysia, Philippines, Australia, Canada, and so on. Thank you.
Thank you, David, for that introduction. Now I would request Dr. Abhishek to share his screen and start with the presentation. Thank you so much. I'll stop sharing. Now, Abhishek, you can share your screen.
Thank you. All right. Can you see it?
Yes, Abhishek, your PPT is visible, Abhishek.
All right. A very good morning, everyone. Sunday morning, Dr. Rupesh. I'm really thrilled to see your knowledge. And I come from India, and India is colorful every day. So we don't need to have an International Color Day. And as you said about mother-in-law, I think I've been married for 15 years, and I think every day should be mother-in-law's day. Because if you make one day only for mother-in-law, I think you are in trouble. So I think for Indians like us, we need to celebrate the color and Mother's Day, Mother-in-law's Day, I think every day. So thank you for introducing me, and I'm very thankful to ISPRP, and special thanks to Manuel. I mean, it's okay if I can call him Manuel, because Manuel is my friend for more than 20 years. And David, thank you. I mean, it sounds nice when you hear something about yourself from your own friends.
Welcome.
So thank you, David, for, I mean, sorry, I'm not calling you doctor anymore, because I will start calling Manu instead of Manuel. So we have that kind of an approach towards each other. So, I mean, I'm one of you guys who started my journey in 2006 as an assistant professor in MCOTS Mangalore. Though I'm from Manipal, Manuel is from Manipal as well, and David was in Manipal as well. So we have a bonding since then. So right now, I just shifted to US in 2023 July. So I'm very new here as such. And as you rightly mentioned, Hawkeye, yes, I went to watch a so-called football match here. They don't call it soccer, they call it football. So this is a place where I'm working as an associate professor. It's a University of Iowa, one of the best ones. And I'm sure those endodontists, those who are listening to me, you must have read a book by Professor Richard Walton, with Professor Tura Binazad, who have written a book on principles and practice in endodontics. And so I've been very fortunate to work with him. And it's a learning experience almost every day. So before coming to US, I was in Malaysia. I spent almost like more than 12 years. And this is the place where I came from. And this is the institution where I was working as an endodontist and as well as an associate dean there for postgraduate continuing education and research. For some time, if I say for almost like 10 years, I've been practicing as a full-time endodontist. But the topic when Manuel asked me to give on a comprehensive approach on ISPRP, I actually believe in this approach, and that is why I thought of giving this lecture today. So though I'm continuing my journey as an endodontist, even in Iowa, where you see here, the institution looks like this, institution looks like this, where every unit, what we have is fully equipped, where you can see, whatever you can think of in endo, we have almost everything in every unit here. So this is the place where I've been working for the last 3.5 months. But something what we have been told and asked to do throughout, like I would like to give a credit to my teachers in Manipal, those who really taught us a very comprehensive approach towards the patient care instead of thinking about only us, that what can we do? I think the most important thing for us is that what we can do to improve the overall health of the patient. And when I say overall health of the patient, it becomes very important for us to understand that what does it mean? For example, if I show you certain cases, if I show you a case where there is a periradicular radiolucency with rate to mobility, everyone may have a different thought process. If you go to an endodontist, I mean, how many of you actually can consider that does this patient need an endo treatment or a perio treatment? I have seen a lot of endodontists and periodontists fighting against each other, saying that, oh, this patient doesn't need perio treatment, this patient doesn't need endo treatment. And that is a common basic problem what we have encountered throughout our journey of dentistry. So when I show you cases like this, when you have a deep periodontal pockets, or when you have a large periradicular radiolucency, or when you see an apical apex of the tooth which have not been closed, or when you have a retreatment case where you see the restoration is going subgingival, or you have a failed root canal therapy because of a coronal seal or because of a bad root canal. Sometimes you may have to think about how can I make this tooth better comprehensively. Sometimes you may have a large lesion. You may think it is because of endo, but it could be because of something else. Now, if you want to go for an endo, for example, you can see the restoration is going to be a very, very important aspect here when the margin of the tooth structure have gone to the equigingival or maybe subgingival close to the bone level. When there is a fracture of the tooth, now we don't know the fracture is running all the way to the apical area or the mid-root area or supragingival area. What if you have a deep periodontal pocket like this? What shall you do? So, I can do a wonderful endo, but I always believe in this, that if you do an endo, but periodontally, if your tooth is compromised, or if you can do a wonderful endo in a periodontally healthy tooth, but the restoration cannot be done, the overall outcome is going to be a failure. Or even then, if you do fantastic, everything, your endo is good, your perio is good, your occlusion rehabilitation is good, but what if the patient cannot maintain the tooth? If the oral hygiene practice is bad, it's going to be a failure. And that is why I thought, let me give a lecture where you can comprehensively consider the patient instead of just considering as a tooth or a treatment what you are capable of doing. So decision-making is an important aspect here. When I talk about decision-making, I'm sure there are multiple ways you can look into the difficulty level. I have gone through the literature. We use, for example, as an endodontist, we use the AAE form, where we look into the case difficulty and we assess based on the guidelines what is supported by AAE. There are multiple indices what you have according to the treatment needs of the patient. But my question is, are we following it? Now, some of you may say, oh, this lecture is very simple. I follow it every day. Because when the patient comes to you, we always look into the endo consideration. We look into the periodontal consideration. We look into the restoratability. We look into the occlusal rehabilitation. We also look into the patient's oral health as well. We also look into the costing involved. Like, this is a very funny thing for me because, see, I started my journey in India where the cost was never a problem because our charges were so low. So even though we want to try out certain things, we can try out. But over the years, like, in last 18 to 20 years, things have changed so much. Well, even back in India, in Malaysia, the charges were high. When in United States, when I've come in, the charges are different. Now imagine if I do a treatment where patient is going to pay $2,000, for example, for one root canal followed by a crown, where he is going to pay $1,000 extra. So the overall treatment is going to be $3,000. Even in India, if you say the overall treatment is going to be 30,000 rupees, for example, if I do the treatment and because of my negligence at the initial level, if the treatment is a failure, patient is going to say it is a failure. And that is one of the reasons what we need to understand, that it is not about what we can do. It is about the comprehensive diagnosis what we make for the patient. And that is why I say, even though we have so many, indices and the case difficulty form, but even then, why are we not able to capture the information the way we want? Maybe we think that these indices are time consuming, or we don't feel confident that we can use them into our day-to-day clinical practice. Sometimes they are too complex because there are a lot of things what we need to capture. And sometimes we think that the compliance of the patient is not being captured in the indices what we have been using. But the most important thing, what personally I believe, that even though we do a fantastic treatment for the patient, but if the patient is not able to maintain the oral hygiene of himself or herself, or the patient is not compliant, or if we are not accepting the medical condition of the patient at the beginning and over the period of time monitoring it, it is going to be a failure. So that is something what we need to understand, and that is why there is something we call dental practicality index came into the picture. Now, if you look at this, I want to show you that even though we have multiple indices, in 2017, Shannon, Patel, and Dowd came up with something called as dental practicality index, which I've been using it for past 6 years, and there have been many papers published on that, and we have carried out the research as well. So now Shannon and when Shannon, he is in King's College London, he's an endodontist. When he spoke to me about this, and then we started doing this in our regular day-to-day practice. And I can tell you the way I practice now, it is more comprehensive than compared to what I was doing it 5 years back. So even though I can say that as an endodontist, I was doing everything right, but once I use this, I won't say that you use the index system, but the way the approach is, it changed my entire perspective. And that's how I'm going to talk about the dental practicality index. Let's not talk about DPI. Let's talk about what all things we need to look into as a dentist, not as an endodontist, not as a periodontist, not as a restorative dentist. I think ISPRP gives you a platform where you can actually use the comprehensive knowledge for the betterment of the oral health of an individual instead of as an endodontist or any other specialization. So I coined this term called SPEC, SPEC. So what we need to do in dental practicality index, we are trying to understand the patient treatment needs based on the restorability, which is structural integrity, based on the periodontal treatment needs, based on the endo treatment needs. And the most important thing, what I realized here is the context, means the local and the general health of the patient. It means in this, what we are doing, along with the restorability, periodontal needs, as well as endo needs, we are also trying to capture the oral health of an individual as well as the medical condition of an individual. Now, when I say the oral health of an individual, that also means the oral hygiene practice as well as the compliance of the patient, that how much patient can do. And I will talk about this, and then you will understand why am I saying this. Now, we give scoring for everything. So, for example, we give scoring for structural part, we give scoring for periodontal treatment needs, we give scoring for endo, and we also give scoring for context. So the minimum score is going to be 0, and the maximum score can be 6 or more than 6. Now, anything which goes more than 6, we say that this tooth does not need to be saved. That means we really are not, it's not possible for us to save the tooth. It is impractical to treat that tooth. And that is one thing which we need to be very careful of, because I always use the word called herodontics. Herodontics means we try to be a hero and try to save everything, thinking that we can do it. But there are certain things what we can do endo beautifully. But as I mentioned to you before, if it is periodontally compromised or restorability is compromised, or if the patient is compromised by its own way, where the medical condition or the oral hygiene or oral health of the individual is not letting the patient maintain that tooth, it has no value. And that's how I'm going to show you. But before I go for it, I want all of you to look into this video, what we prepared for you guys. It's not a long video, it's around 5 to 6 minutes video. I hope you will understand, and then I will take you through. So just let me know if you are able to hear this voice.
Hello everyone. Today,
Is it
we are
audible
going
to you?
talk about
Yes,
dental
it's audible.
index.
Yes.
It is an index that we help us out clinically and every day. We will talk in depth in a while, so now just sit back, relax and enjoy this video. From here, you will get introduced with Dental Practicality Index, DPI, its indication, and the way to use it. According to Dawood and Patel, the Dental Practicality Index has been designed to describe on a clinical level the practicality of dental restorative treatment. In other words, it provides a framework for assessing teeth and planning treatment. Have you ever been confused in clinic due to being uncertain of the complexity of a case? Therefore, don't know how to approach the case and being low in confidence? Have you also faced the issue of lack of guidance or guidelines to follow when providing a treatment plan? The benefits of DPI are, first, to allow clinician to identify the complexity of the case, then classify and approach the case according to the complexity. Therefore, able to provide a better and more precise treatment plan. Also, it can boost the confidence of a clinician. Now, let's dive into Dental Practicality Index, DPI. DPI is an index that will cover 4 aspects of a tooth, which are structural integrity, periodontal, endodontics, and context. We can easily memorize all these 4 aspects with a simple mnemonic, S, P, E, C, SPEC. According to DPI, we have to score each aspect respectively, then total up the score from each aspect. If the total score is 6 or more, then the tooth is considered untreatable. In terms of structural integrity, we will give score 0 for cases with unrestored tooth, or, the existing restoration is in optimal condition. In other words, no treatment is needed. We will give a score of 1 for the cases which requires simple treatment, such as simple direct or indirect restoration. If the tooth presents with minimal tooth structure, or it has a subgingival margin which requires post-core, it means the treatment will be complicated. Therefore, we will give such cases a score of 2. If the case presents with inadequate ferrule, the tooth is considered unsalvageable and it is indicated for extraction. Therefore, we will give such cases a score of 6. In terms of periodontal aspect, we will give a score of 0. When the BPE is 0 to 2, in other words, when the probing is less than 3.5 millimeters. We will also give a score of 0 to a case if the periodontal disease is successfully treated. We will give a score of 1 if the treatment needed is simple. For an example, if the BPE is 3 or the probing depth is 3.5 millimeters to 5.5 millimeters. We will give a score of 2 to cases which require complex treatment. For an example, if the BPE scoring is 4 or the probing depth is more than 5.5 millimeters. We will also score it as 2 if there is short root ratio, especially if crown lengthening procedure is indicated or done. In the case of grade 2 mobility or any furcation involvement, score of 2 will be given to. If the case is present with untreatable periodontal disease, a score of 6 will be given and extraction of the particular tooth is indicated. In terms of endodontics, we will give a score 0 if no treatment is needed. For an example, if the pulp is vital or the existing root canal therapy is in optimal condition, we will give score of 1 if simple treatment is indicated. For an example, when the canals are simple and straight, indicating a simple root canal therapy is needed. When the canals are sclerosed, curved, perforated or broken, instrument is left, a complex endodontics treatment is required. Therefore, we will score such cases score 2. When an untreatable root canal system is presented, we will give such cases a score of 6 as extraction of the tooth is indicated. The next aspect is context. It is split into local context and general context. Local context relates to the oral environment and the patient's ability to maintain their dentition, while general context includes the impact of treatment in the wider context of their social, dental and medical history. In terms of local context, if the adjacent teeth are healthy or the existing restorations are in good condition, no treatment is indicated. In terms of general context, if there is some history of medical condition but it won't affect the treatment plan, for example, history of head and neck radiotherapy, hypertension and diabetes mellitus which are under controlled, then, no treatment is indicated. Therefore, we will give a score of 0 to such cases. In terms of local context, score 1 refers to the adjacent teeth that are planned to have bridge. In terms of general context, score 1 refers to medical condition that will affect the treatment plan but the medical condition doesn't require hospital setting. For example, uncontrolled diabetes mellitus and hypertension. For score 2, the local context refers to prosthodontics treatment plan for multiple teeth, while the general context refers to when there is high caries risk or rate, poor oral hygiene, parafunctional habits, extensive tooth loss due to parafunctional habits, limited mouth opening, severe gag and medical condition that will require hospital setting and affect the treatment plan. For local context, score 6 refers to keeping the tooth would complicates the treatment plan, for example, overly supra-erupted tooth. While for general context, score 6 refers to potentially life-threatening medical conditions where the objective of the dental treatment is pain relief only.
So if you look at this, basically what we are trying to do, we are trying to capture all the information at the beginning. Now, as I mentioned to you before, that we may think that we are capturing all the information, but with this mnemonics, SPEC, we are trying to capture in such a way that we don't miss out any information. So as I mentioned to you in my previous video, that 0 means when the no treatment is required, but 1 means when the simple treatment is required at the structural part, at the periodontal part, as well as in the endo part, and when it comes to contacts, which is the oral health as well as the systemic health of the patient. While number 2 would be anything which you need complex. For example, if you go for structural way, you need to go for post and codes or subgingival restorations. When you go for periodontal surgical therapy, if you're going for non-surgical therapy, for example, just simple oral hygiene prophylaxis, like for example, scaling or root planing, then I will give score 1. If I need any surgical therapy, or grade 2 mobility where I may need further treatment, then I will have to give score 2. And the same thing goes for endo as well. If the patient is having high caries index, I tell you, like if you do a fantastic treatment, but if the patient is not able to maintain the oral hygiene, your treatment is going to be a failure. So we have to focus on high caries and bring it down to low caries. And I will talk about this. So it's a comprehensive approach. When it goes to 6, we have to remove the tooth or we are not able to save the tooth. So let me show you by giving some examples, and then I will tell you what all things we have done throughout. So for example, I will show you some cases here where this patient was referred to me for the retreatment. When I look at the SPET part, like I look at the SPEC, what you can see here is it's very simple. You can see here SPEC, that means you can see the structural part is a simple indirect restoration, what you need. The probing depth is less than 3.5, so I'm going to give score 2, because if I'm removing the crown, there is a possibility that the underlying tooth structure may be compromised and I may have to go for subgingival restorations or maybe a post and core. The root canal looks simple to me and it's an individual problem. So the overall score is 3. But my focus is that, okay, my retreatment is easy, but the restoration I need to be very focused on. So that helps me to understand from the beginning, and I inform the patient that there is a possibility that you may have a fracture tooth inside, or there is a possibility if I remove the crown, there is a possibility of a fracture. And if not, then you may have to cut the crown or go through the crown. So there are multiple things what you need to consider before you start. So what did I do? I went ahead and I removed the crown and I did the retreatment because I know the endo is not a major problem here. The major problem is restoring the tooth in an ideal way. And you can see over here. Similarly, another patient where I can see the patient is having a crown, which is having a bit of an amalgam core going all the way into the root canal. There are 2 separated instruments. You can look at the distal canal is long, which have not been negotiated. And then the patient is having high caries. So when I look at the SPEC part here, I need to say that the overall score is going to be 6 because I need to think about the subgingival restoration. I need to think about the endo because the complex treatment is needed to remove the separated instruments. I need to negotiate the calcified canal. And not only that, I need to bring down the caries level to minimal level. So you see, it's a borderline case. So when I'm talking to the patient in advance, that I can always tell that, okay, there is a possibility that I may not be able to save the tooth due to the reasons 1, 2, 3, 4. And that's how I work in that way. So in that case, what did I do? I removed the crown, I removed the separated instruments, negotiated the canal, and you can see my canal has been complete, root canal has been completed, followed by the restoration later on. But what is the advantage here is I'm able to maintain and inform the patient in advance that what are the difficulties or challenges you may face and I may face as a clinician. You are having high caries. I will talk about this, that how to bring the caries level from higher to medium and medium to low. So similarly, you can see a case where there is a deep periodontal pocket. It is a tooth number like molar, third molar, where we are having this problem when there is a third molar that you see there is a curved canal here. Now, what am I going to do? I may need a simple indirect restoration. Some of you may think that why am I saving the third molar? Because the first molar is already missing. If I remove the third molar also, the entire load is going to be on the second molar. So that we need to be very careful about. So what did I do here? I actually looked into this. The periodontal probing is going more than 3.5, but less than 5.5. And there we used to use BPE score, which is more of a British system. But in the US, they have a different classification for periodontal disease. I'm sure all the periodontists, those who are here, they must have gone through it. And what am I doing here? Endo is not a problem because though I see a third molar with 3-rooted molar with slight curvature in the mesial root, but that is manageable and it's an isolated dental problem. So what am I going to do? I understand that it's the third molar, the accessibility is going to be a problem, but the major problem is I have to maintain the oral hygiene of the patient and the periodontal condition of the patient. So I'm focusing on that. So because of that, I could do this, and then you will see I can actually you can see here what did I do? I opened up the tooth. I went ahead with the non-surgical periodontal therapy along with my endodontal treatment, and you can see the overall treatment was carried out in a proper way where you can manage your endo part, you can manage your period part, you can manage the restorability. Why did I give a full coverage restoration on this tooth? Because of the occlusal load. So what is happening? I know that restoration, what I need here could be just an amalgam or composite resin restoration. But because the tooth structure is missing on the first molar and patient may not be going for the treatment to replace the first molar. So what did I do? I placed a full coverage restoration, which will help you to have a longer oh, it is showing that it could shut down. So if my window shut down in 10 minutes, I'm going to come back. So please don't go away. My computer is showing me some problem here. So this, am I audible to you, all of you?
Yes, Abhishek, we can see your screen and you're audible.
Yeah, but Manuel, somehow my laptop is showing that in 10 minutes, there is a possibility of restarting. I don't know why. But if it does happen, don't get panicked. I'm going to be back.
Yeah,
okay?
yeah, no, not an issue, not an issue.
I don't know. I mean, somehow I don't know what is happening. So I'll show you another case where patient has come to me with a deep periodontal pocket. You can see here the root canal treatment looks good. The coronal seal is a bit compromised. There is a large periradicular lesion, a grade 2 mobile. Now, the thing is, some of you may say, oh, let's go for extraction. Some of you may say, oh, let's go for perio treatment. Some of you may say, oh, there is a fracture, so let's go for extraction straight away. But what am I doing? I'm trying to find out the information through DPI. The structure-wise, I can manage. Periodontally, it's a compromise. Endo-wise is simple, retreatment, and patient has an isolated problem. So what is going on? If there is a fracture, I need to look into the fracture realistically. And what did I do? I went ahead for CBCT, okay, and then I will show you. But before I went for CBCT, you see there is a deep periodontal pocket all the way up to almost to the apical third of the root. Now, when I'm having this, that gives me an alarming signal that there is a narrow pocket and there is a possibility of a fracture. But am I able to see the fracture through my two-dimensional image? It's really difficult for me. So what did I do? I went ahead and I did my CBCT scan here. You can see, and you can see some pictures, and you can see the video that is showing you that if there is no fracture. When I'm 100% sure that there's no fracture, what did I do? I went ahead with the retreatment because I understand the periodontal part is clear. And if I went ahead with the non-surgical periodontal therapy along with this, and you can see the healing happening. Now, some of you may think that, oh, what if your periodontal probe you have just kept on the tooth and you're not going in? I will show you here. When patient came to me previously, the periodontal probe went all the way up to the middle third or an apical third. However, when I'm trying after 3 months, you can see the blanching. It is going all the way, maybe up to 3 or 4 millimeter deep inside. But you look at this after a few months, maybe 6 or 7 months, if I'm not wrong. I'm really trying to push my probe in. It is not going in. And that shows if your diagnosis is right, you can have a better prognosis of the tooth. And this is something which I always say, don't jump to the conclusion but just by doing one investigation. Carry out the investigation thoroughly, and then you will be able to do the treatment. This is a very interesting case. And, you know, it's a grade 2 mobile tooth, 93-year-old man, 93. He's a father of one of my professors here. When I was in Malaysia. And then this patient, when I was doing the SPECT part for him, this is like borderline because endo is not a problem. The problem is the medical condition of the individual. He almost had all the problems in medically, whatever you can think of. Plus, he's got a deep periodontal pocket, grade 2 mobile tooth, and I'm asking him to go for extraction. He says, no, I don't want to lose my front tooth. And believe it or not, at the age of 93, he had all his teeth saved in his mouth. So what did I do? I understood. I splintered the tooth for a while. I got my period consultation done. We cannot make the bone regeneration at the interdental area, but by doing endo, you could see I could save the tooth. And this is after almost 1.5 years. He's still alive. We could save. There was no mobility thereafter, but we had to go for non-surgical periodontal therapy because surgically it was impossible for us to save the tooth otherwise. So what I mean to say, by comprehensive approach, you can actually save the teeth the way you want to. Now, for example, this is a perfect example of the combined lesion, you know, where the problem is endo. The main problem is endo, but some of you may think it's a J-shaped radiolucency and there is a possibility of a fracture. Let me tell you, there was no fracture when we looked into. But what did we do? We actually tried to figure out through SPEC that what is going on. The problem is the restoration because it's going to be deep restoration. It may need post and core. We need non-surgical periodontal therapy. We also need endotherapy, but you also need to understand patient is having high caries risk as well as the oral hygiene was not up to the standards what we are looking for. So in this, if I do an endoperio treatment, but if I don't reduce the caries level down or risk assessment down, it is going to be a failure for sure, I can tell you. So what did we do in this? After considering everything, we informed the patient, we are trying to save your tooth. We will do your endo, we will do your perio. At the same time, we have to provide you some treatment in the office, and you have to maintain your oral hygiene out of the office. And that's how we did. And you can see the healing happening. So what did we do? We did the retreatment from an endo point of view, but at the same time, we restored the tooth back. We also informed the patient, we applied fluoride varnish every 3 months. We informed the patient that we took the patient's diet chart and everything, and we reduced the caries risk from high to moderate, moderate to low, and you could see the overall outcome. I will talk about this in a while. So your treatment strategies, especially when it comes to endoperio lesion, I have seen a lot of people fighting that you need endo, you need perio, tooth is vital, tooth is responding to the pulp sensibility tests. I can tell you this is for endodontists, especially in multi-rooted teeth, even a small amount of pulp tissue is vital in one of the canals, patient may respond to your pulp sensibility test. And the best pulp sensibility test is a cold test, not electric pulp testing. We don't do heat tests at all nowadays, especially in the US here. We hardly do heat tests. We do believe in cold test. So for the combined lesion, I will always go for a endo treatment first. I may go for non-surgical periodontal therapy, which is scaling and root planing. And then if it is endoperio lesion, I will go for multi-visit endo for sure, because it will allow me to have a better debridement. If there is any iatrogenic error that has led to the endoperio lesion, I will manage that part as well. Recall the patient and assess. Now, when I'm recalling the patient and assessing the patient, in that case, I will see whether I really need to go for surgical periodontal therapy or not. So when I need to go for surgical periodontal therapy, I will see how deep is my periodontal probing. And you can see in this slide, if the periodontal probing depth is less than 4 millimeters, and if the patient can maintain the oral hygiene, I will not go for surgical therapy at all. But if the periodontal probing depth has got more than 4 millimeters or less than 6 or more than 6, then I will go for your bone regeneration therapies, and I will ask the patient to please go to a periodontist and get your consultation done and get your treatment done. But what is happening, instead of deciding this in the end, I'm deciding this all in advance and informing the patient well in advance that I'm going to carry out this treatment for you. And if it doesn't work for you, you may need this treatment. And I am going to bring my perio friend and our periodontist, and I'm going to ask them, okay, can you please consult and can you please give your advice here? Then I'm going to bring in my prosthodontist friend and say, can you please look into the case? How much do you think we can save the tooth? And what happens is, when we are following this pattern of spec, when we are looking into the structural point of view, periodontal point of view, endodontic point of view, oral health condition of the individual, as well as the medical condition, compliance of an individual, the risk assessment of an individual from a perio as well as from the caries, combining all this information together, definitely you will have a better prognosis for the patient. So risk assessment, when it comes to caries risk assessment, I've been working on this, and I've given a lot of lectures on caries risk assessment as a part of ICDAS and ICCMS. Some of you must have heard my lecture before on this. I will give you a simple way of risk assessment, what we do for every patient. Manual, just to inform you, I may go out of this platform for a minute or two, because I think I'm almost at the verge of restarting. If it does happen, please don't get panic. Yeah,
not an issue. We'll wait. We'll wait.
Yeah, because something, I don't know, it is showing me some red line. I don't know why.
Okay.
So there are various risk assessment tools, starting from Canberra. You must have heard about traffic light system. You must have heard about from Singapore, and you have plenty of risk assessments. Okay. And that's how we try to understand the caries risk, that how much this patient can develop new caries lesions. Now, when I was going through the literature, there are a lot of papers published on risk assessment, a lot of systematic reviews and meta-analysis. I could not understand.
Okay, so this is Dr. Manuel, the scientific chairperson. Dr. Abhishek, his computer just, I think it's rebooting. So please be online. I think we have some more information to get from him. So please be online. He'll join us soon. Meanwhile, yes, sir. Please do continue.
No, I was just saying. Meanwhile, all those students who have been listening to Dr. Abhishek, kindly do post questions. I think Manuel probably were trying to say the same thing.
Yes, sir. Exactly. I was trying to say the same thing. Thank you so much.
So please do post your questions and let it be anything. A question is a question. So whatever popped in my mind, we have a lot of new information which Dr. Abhishek has just told us, and I'm sure it would have excited your minds. So kindly do post any queries, big or small, it doesn't matter. So please do.
And while you're posting your queries, a couple more information. One is at the end of the presentation, I will be putting a link. That link is for the feedback. Once you fill in the feedback, you will get your certificate. That is how it goes. So if you have any queries, regarding your participation certificate, you can email me directly later. Okay. And please do wait till the end to access the link. And in your feedback, based on your feedback, we plan our programs based on the feedback as well. So we've got feedback regarding the topics required for the webinar. So the next topic, as per the feedback, we'll be speaking on digital dentistry. Basically how it helps in implant placement and planning. So the November webinar will be based on that. The details will be shared with everyone later. We will be emailing it to you. So when you give your feedback, please give an honest feedback. And if possible from our side, we'll arrange some topics, interdisciplinary topics based on that. Thank you.
Also, for the information of all the faculty members who have logged in later, kindly percolate and spread the first ISPRP UG convention brochures to the heads of departments, the principal, the dean, and see that there is a good participation from all your institutes for this first ever event, the ISPRP event. I'm sure all your postgraduate, undergraduate students would benefit out of it. The brochures have been posted and throughout the length and breadth of our ISPRP reach. So I'm sure you probably will find it on our ISPRP Facebook pages also. So kindly do that.
Dr. Abhishek will be with us soon. So it's 1 a.m. in US. So I think when its system is getting rebooted, I don't know why. So, but he'll be with us soon. So please be patient. Please wait.
If somebody wants to sing a song while we wait, you're all free to do it. Any singers in the group want to sing and entertain us? Manuel will be sending you a gift if you do that. Manuel.
Yeah. Yes. And very important regarding awards, I just wanted to tell you one more thing. I don't know, some of you might know it. After every webinar, we'll be having a post-webinar quiz. So it's been happening. This is our 10th webinar. So I think Abhishek is sharing the screen. Abhishek, we can see the screen, Abhishek.
I'm sorry for the hiccup. I don't know, something went wrong with my laptop. Suddenly started showing that it's going to restart.
Not an
All
issue.
right, so
before
can
I was just saying something to them. I'll just complete that. Abhishek,
yes,
one
please.
second. So I was telling the participants that this is our 10th webinar of 2023, and we have conducted 9 post-webinar quiz. After this webinar of Abhishek's, after 2 days, we will be sending a link for a post-webinar quiz. And the member who gets the maximum cumulative score will definitely get a certificate and award during our national conference. So please do participate in the quiz as well. Okay. So thank you, Abhishek, for joining back, and we'll continue with the program.
I'm so sorry for the hiccup, Manuel. Like Sunday morning, I don't want it to be like that, but in case, I mean, technology is good, but sometimes it gives you a bit of hiccups. So I was talking about the risk assessment, and I mentioned to you guys that we have a lot of assessments, and if you look at the literature, there are a lot of systematic reviews and meta-analysis. And one question which always came to my mind for so many years, that how standardized the careers risk assessment tools are, how effective they are. And, that gave me a lot of insight, because when I was getting my training with Nigel Pitts and Dr. Kim Strand from Copenhagen about ICDAS and ICCMS as a restorative dentist, we figured out a couple of things. That though there are so many risk assessment tools, if you look at the literature, and I'm sure all of you must be using it, every tool relies only on 3 aspects: whether it is reliable, is it valid, and how is the responsiveness. Whether reliability means that if we are trying to gather the information and different conditions, are we getting the same information? Or even if we are trying to validate the tool, means we are getting to measure what we claim to measure. And if we are doing some investigations and some, I would say, some treatment strategies we are involving, whether that treatment strategy is helping the patient or not. So what we started doing in IMU, because when we looked into this, we could realize that there is a very insufficient evidence which can say that one tool is better than another tool. So I would say those who are using any tool for the caries risk, you please continue doing so, provided you are getting the information what you see in front of your screen. So in IMU, when I was there in Malaysia, or even now I'm using it, I started looking into the patient-related factors, the intraoral factors, and when I'm looking at the tooth as a caries, I'm not just looking at the extent of caries, I'm also looking at the activity of the caries. And that is why, and this is an auto thing. I mean, I cannot show you here auto because of, I'll have to go out of the screen again, but you can see the three lights here, the green, yellow, and red. It automatically tells you, based on the information what you have taken from the patient, whether your patient belongs to high likelihood of developing caries, moderate likelihood, or low likelihood. So basically, what am I trying to tell you here? That you are not looking into the structural point of view, or a perio point of view, or endo. You're also looking at the oral hygiene and oral health of an individual along with a medical condition. And that is going to give you a very, very comprehensive picture. So coming back to the SPECT part, that now, for example, this patient who came to me for the retreatment because patient was having a bit of tenderness on the tooth. When I look at this tooth, as an endodontist, I feel, wow, I can do it. I can remove the post and everything is okay. I can retreat this. But you are not realizing the restoration, which is going to be very close to the bone level. And that is the mistake what we do, because we think according to DPI score is 4, but we also need to look into the restorability part of it. And if you look at this, like I can remove the post, you can see in my screen that I'm trying to remove the post. As an endodontist, you can remove the post, and the post is going to come out easily if you are using the right technique and you are using the ultrasonics. But what about the restoration? So in this case, I went for the post and core. I could go ahead with the post and core, but the problem is my restoration is compromised or not. If the margin of the crown, which is going to be later, is going to be very close to the bone level, I think prosthodontist is not going to like it, and a periodontist is not going to like it. So if we actually look into this in advance, it's going to be easier for us. Now, for example, look at this case. Now you can see a separated instrument at the apical third. As an endodontist, I can do it. But what are the problems we have? We have to go through the crown or remove the crown. If we remove it, then whether the crown, the natural tooth structure is going to be compromised inside or not compromised. Do I need to go for a post-and-core or no post-and-core? May I need to go for a crown lengthening procedure? So I need to really look into all these features before even I start the treatment. As I told you, I can straight away think about the separation of instrument is not going to be a major problem for me as an endodontist. But it's not about only endo. It is also about perio. It is also about restorability. It is also about occlusal rehabilitation. It is also about the oral hygiene of an individual. And you see, definitely I could remove the file from the tooth, as you can see here, and I went ahead. But what did I do here? I did not remove the crown because I was not sure that if I remove the crown of an individual, then I may end up in a problem. So what did I do? I went through the crown, I removed the file, restored it, obturated and restored it. So what is happening here? I'm trying to be more conservative instead of more aggressive. So another tooth, which is a third molar. Now the problem here is, as I mentioned to you in my previous case, it's not the third molar and the third canal. It's about the mouth opening of an individual. So now when the mouth opening is limited, here the patient consideration is there. I can do a wonderful endo in this and patient will be benefited. But what challenges do I have during the procedure? So if I'm understanding that part, if I'm understanding the EC part, I know the major problem is going to be an endo problem because of the curvature, because of the limited mouth opening, and because of my accessibility towards the tooth. So when I understand this, I can plan the patient treatment better. And that's how I did. If you look at this, I could manage this tooth. I'm not going to go into endo details here because I want to give you a comprehensive treatment planning and you can see the healing happening. I'm not going to go into technical part of endo that how did I do endo? I think for that, an endo forum, I can talk more about it. But what am I trying to tell you here is you need to consider the endo part, perio part, restorability part, as well as the complexity of the case based on the DPI. Now, another case where there was a fracture. Now, I don't know how deep is the fracture. So what do? I look into the case and I say, okay, if the fracture line is going to go below the cervical line or if it's going to be supragingival, if it is below the cervical line, then do I need to go for crown lengthening? Or I may not be able to save the tooth at all and the fracture line is going all the way. So I need to think about it. And you see it is scoring high, which is number 5. So it means it is not only about the endo, it is also about the patient's oral health. It is also about the restorability. So what did I do in this case? To understand this, I went ahead, I put the dye to see how deep is my tract line. Under the microscope, I saw, okay, it is supragingival, where I don't need to go for crown lengthening as such, but I definitely need an ortho band, which can stabilize my tooth. So here, the restorability is another aspect what we need to look into instead of just endo. Endo is easy here. Straight canals, premolar, you can go ahead with that. But you need to consider that during the endo, I need to stabilize the tooth by placing the ortho band. Once I finish my restoration, immediately I need to go for full coverage restoration without any delay. If I really want to save the tooth for a long-term success. If I miss it, if I say, okay, I have done endo, I have placed a an ortho band, and there can be a delayed restoration, you may lose the tooth. So this is something what we need to try it out. So based on that, when I was looking into this, into my clinical practice, you can see another case of a failed endo. See, here in the US, I don't know why, they like to go through the crown, which I don't believe in, but somehow they really believe that because they need to go through the crown instead of removing the crown. But I believe that you have to remove it because you don't know what is happening underneath it. There may be a crack, there may be caries, there may be a restoration which is compromised, which may lead to coronal leakages. So I believe in removing it and then reperforming the entire procedure. So even here you see it is on the higher side because of the restorability is a problem, because after removing, you may see a compromised tooth structure. endo is going to be easy, but this patient is having other issues as well when it comes to medical condition. I'm not giving you the medical conditions over here as such. So what did I do? When I retreatment is going to be easy. If you remove the crown, you do the procedure, and then you can see the new crown was placed and you can see the healing happening. So when you are actually diagnosing the case in advance, you can do a better treatment. So when I was talking about this, then we thought, okay, then Shannon and I, we decided, okay, let's do a research on this, whether it is only us as a experienced dentist, those who have been working for 15, 20 years, because I believe I am still learning. I don't believe that for last 20 years, if I've been doing endo, that means I know everything. I know only 5% of it, 95% I still need to learn. So we decided, okay, let's do in undergraduate level, whether they get benefited or not. So what did we do? We wanted to compare the ability of treatment planning, making the treatment plan and the decision making for dental undergraduates after the DPI training. And we wanted to see the confidence level, whether they are confident to make the decision after the training. And we also wanted to compare, is it going to be only the senior students going to be benefited, or even the junior students, like year 4 students can also take up and can perform the same way as year 5 students, those who have got a bit of more clinical experience. So what did we do? We got everything right. First, we got the ethical committee approval, and we had consensus panel, including Shannon in that. And we created 15 clinical scenarios, which were actually seen by all endodontists, restorative dentists, periodontists, as well as a prosthodontist. And we came out with 15 clinical scenarios with a consensus that, okay, this is the treatment option we will give for this particular clinical scenario. So that was our training material. And then what did we do? What you see here as a part of the video which I showed you, this is just a very short part of the video which I've shown you in my presentation today. That was also a part of my training, where we had to have a clinical discussion with a lot of cases. So the 15 clinical scenarios, what we gave it to them, we did not discuss about those cases at all, but we discussed a lot of cases as I have discussed with you today. So what did we do? We did take the pre-DPI test, means we gave them those 15 scenarios, and we told them, okay, answer the choices, what you will do based on this clinical scenario. Then we trained them and we asked them to answer again. And then what did we do? Because you may forget about all these things after 1.5 months, after 6 weeks, we asked them to do the same clinical scenarios we gave them, and we asked them to answer again. And then we did all the analysis, and we also looked into their confidence level, that whether how good they felt after the training, whether they feel more confident when they are answering these questions. And I will show you a bit of an example of clinical scenario, what we have given out of 15 cases, where we are giving them an information about the patient based on whatever you have here. And then based on this, they have to come out with an answer, what kind of a treatment they would like to do for this particular patient. And the scale what we used for the confidence was an academic behavioral confidence scale, where they have to see from 1 to 10, like VAS scale, visual analog scale, where they can say, okay, I feel confident like number 8 or number 9. And based on that, when we did the entire experiment, we realized that the pre-testing, whether year 4 or year 5, it moved from 7 to 9. So you can see the individuals, like all those 94 students, what we gave, they felt really confident and they could do a better treatment planning, and the decision making improved from 7.53 or 7.43 to 9 to 9.09. And even though after 1.5 months, when we asked them to retest, it dropped down a bit, but not significantly. So overall, I could say the DPI training, when we did for them, it improved their treatment planning scores significantly. They felt really confident by performing the decision making, because they can comprehend all the information in one umbrella instead of going here and there. Because I have noticed sometimes they will say, oh, the crown root ratio is there. Sometimes they will say the bone level is not like that. But because of this, they can comprehend all the information. They can capture everything, each and every detail, and then they can come out with a better diagnosis and better treatment planning. And that's how we could say that it made a positive impact on their treatment planning and decision-making skills. So overall, I could say that DPI, I mean, I'm not promoting DPI, but I'm just trying to make you understand that we have to, like ISPRP is a prosto, perio, and restoration. Similarly, I'm saying SPEC, which is structural, perio, endo, and context of the patient, provides a structural format to allow dentists to assess the interrelated factors. It is a comprehensive, holistic approach for the patient-centered care instead of what I can do wonders. So I would say this actually allows you to have a better communication with the patient, keeping the patients in the center, and it improves the overall prognosis of the treatment what you provide to the patient. So I would say this is something with what we have been doing it for so far. And now we are planning to carry out this research at the multi-center level. Actually, I had presented the similar presentation for IES, which is Indian Endo Society, because I wanted them to think out of the box, just not into endo. And then we also came out with we are working on some apps where we can use it and make it more simple and easy for you to carry out at the chair side level. So this is I'm trying to do at the multi-center level. So with this, I would like to say thank you, everyone, for having me here. And sorry for the hiccup for a couple of minutes during my presentation. And in 2021 or 2022, I don't remember, I was featured on one of the international dental magazines, and they asked me, what is your lifelong mantra? And I said, my lifelong mantra is be honest to yourself and develop a passion for lifelong learning. And what is passionate for me, the passionate means is you have to be positive about whatever you do. And those people who think ambitions are not good, I would say you need to be ambitious, because if you're not ambitious, you can never achieve what you want to achieve in life. Over ambition is a problem. Ambitious you have to be. You have to be sincere, scientific, innovative, outcome-based, nimble, adventurous. The most important thing I would say, you should be trustworthy. People should trust you what you do. So patients should trust you what you do. And that is something which I have been telling you for the last 1 hour. And with period of time, I would say ethics are more important. See, and when you are young, you want to do a lot of things. But I think with time, you understand how ethical you need to be towards yourself, towards your patient's care, and towards your treatment plan and whatever you do. So with this, thank you so much, ISPRP and all the members for inviting me here and giving me this platform to share my work with you. Thank you, one and all. Thank you.
Thank you, Abhishek.
Yeah.
Sir, please, we'll have the discussion. We have 5 minutes.
Sure. Perfect. Let me once again thank you, Abhishek, for taking the time off. And,
sorry for the hiccup. I'm so sorry for that.
Absolutely. Anything can go wrong, out of your window, so anything can go wrong. So I've never had, even in a conference, we normally get these hiccups with the audio and I've never seen a conference go, pitch smooth. So that really was a scintillating and excellent, an eye-opener, I think, discourse by Dr. Abhishek. And like I said earlier, multidisciplinary and interdisciplinary is the core of what ISPRP is all about. And probably this was one of the most important and apt webinar we have ever had in our platform. Thanks to Dr. Abhishek and Dr. Manuel. Thank you for bringing him over. And what you said about the spec and DPI, I'm sure all the students who have attended, I'm sure they'll put it into practice. Let's take up a few questions. I wish there were more questions, because Abhishek had promised that the winner of the best question would get a month's supply of popcorn from Iowa. Iowa is the largest producer of corn in the world.
Yes, you're right.
So Abhishek had promised a month's supply of popcorn, but unfortunately, now let us see.
I think you are underestimating me. I can supply for a year.
All right. Okay. Now we have a question for you, Abhishek, from Dr. Lochan Kuller. What he says, majority of the questions are based, I think, out of the spec and DPI, because it's probably something which have ignited people's mind. Lochan is asking, good evening, Abhishek sir, for the medically compromised patient. For a patient who probably has undergone radiotherapy, where extractions are usually probably not advised. If you get a DPI score of around 6 or above, how would we go about it?
Yeah, that's a very good question. And then you see, you need to understand that it's not only medically compromised patient I'm considering. I mean, if the medically compromised patient is there where the radiotherapy has to be done and the patient cannot go for extraction, in that case, I will also look into the restorability. I will also look into the endo part and perio part. For example, my score goes more than 6, but I cannot restore the tooth. I will just go for the, the symptomatic treatment. So for example, I will inform the patient that, yes, your tooth is going to be difficult for me to save, but as you are in pain because of deep caries, for example, I will just do your endo treatment. Maybe I can just do the pulpectomy or remove the pulp tissue, place the medication and temporize the tooth. And I may not do anything else. So where I'm going for the symptomatic treatment. Or for example, if the patient is having periodontally compromised tooth structure where you are having a grade 2 mobility or grade 3 mobility, I may request if a periodontist, he can just do a non-surgical periodontal therapy, maybe scaling and root planing in that case, and can maintain the tooth for a while. So we can see, this is something what we have to analyze based on the condition. Otherwise, what happens is we look only from one aspect and we say, okay, let's do this or let's do that. So here, whenever we are having a combination of problems, we need a combination of dentists coming together and performing the procedure for the patient. So I would rather go for symptomatic relief for the patient instead of going for extraction because it has been compromised based on the medical condition of the individual. So it's a very good question, actually.
Yeah, at least Abhishek, it's rest assured that you have made people start thinking, in that direction. So I think the primary objective of your talk today has reasonably been achieved, I think.
Thank you.
And we have a question from Dr. Anahida. She says, if you get a score of 6 individually in your DPI score, in one of the, if you get an individual score of 6 in one of the spec criteria, any one of the spec criteria, should we directly advise the patient for an extreme step like an extraction, or we still go ahead with the conservative line of saving the tooth in case the patient doesn't want an extraction?
If any, this is a great question again. If any individual parameter is 6, and if you are adding one more number in that, it becomes 7, for example, I will 100% go for extraction.
Okay.
If anything more than 6, until 6, I will try to save. The moment it goes more than 6, even in one parameter, that means that tooth is not worth saving.
Right, perfect. So, which means that all of these 4 parameters, the clinician also has to study well. You cannot just randomly.
Yes.
So that's the most important thing.
Yes. So what happens is, see, I am not promoting DPI. I'm not promoting anything. What I'm promoting that our mindset. I've been practicing endo like Dr. Manuel here, or Dr. David has been doing perio, Dr. Rupesh has been doing prosto. But what happens is, any tooth I give him, Dr. Rupesh, for example, Dr. Rupesh, can you put up a crown on top? He will say, oh, yes, I can. But what if the tooth is having grade 2 mobility?
Absolutely.
What if he puts up a crown, but the endo treatment I have done is a failure? His work is going to be compromised there.
Absolutely. So that's absolutely hitting the nail on the head. So there's another interesting question by Smita Shetty. As a clinician, her concern is to motivate the patient to undergo staged treatment, like endo, perio, etc. But the patient would rather prefer an extraction and implant. So that is, yeah.
Okay, that's something which we see almost every day. Now that is why if you look at this, I said normally what happens is I tell you, I come from a same background where we are all there, where we think that what wonders we can do. As an endodontist, I think, oh, I can do a beautiful endo here. but we forget about the patient. Patient is the one who is going to save your tooth or his tooth or her tooth. Now, if the patient says, you know what, I cannot maintain my oral hygiene, or I cannot pay for your treatment, for example, I will say, okay, I will respect you. I will say, okay, I mean, I can offer you this, but if you can't, for example, restaurant have got 10 different kinds of dishes in menu. He can give you 10 dishes, but you are medically compromised. You cannot eat any one of them. Can he force you to eat? No, cannot. So what happens there? You are not eating anything because you cannot eat anything because of your medical condition. Or what if you don't have teeth? Can you bite on that? No, you cannot have food. You cannot enjoy food. Similarly, if the patient is not able to maintain the oral hygiene, or you are not able to maintain the risk assessment of the patient caries wise or periodontal wise, patient says, I cannot do it. Okay, we don't do it. But what we do, we educate the patient based on what we have done. So we inform the patient, we can do this for you. Now it's ultimately your tooth. If you want to save it, you save it. If you don't want to save it, you don't save it. Very simple.
Absolutely. Absolutely. And Dr. Ankita, your question, I think Dr. Abhishek has already answered earlier regarding the DPA score of 6 and above. So I'm sure you're satisfied with what Dr. Abhishek has said. Dr. Smita Dutt, she says she works mostly for competency-based learning in institute. However, it is pleasant to see that restorability is being considered by an endodontist like you. So that's basically a compliment for the for the year supply of popcorn that you promised. And again, Dr. Mohammed Sishan Ahmed, probably that's the last question we will take. So what about those patients who visit just for endodontist, to an endodontist just for pain management and has a negative attitude towards comprehensive dental treatment? How can we manage such patient? Pain relief and the patient is out and gone.
I think I should give supply to this guy. I think he's hitting the nail. Okay, I'll give you a very simple answer to it. You need to understand that as a layman, when I say layman does not mean literate. Layman means those who do not understand dentistry as such. I mean, if I go to a medical doctor, for example, for my orthopedic doctor, where I have no literacy about bones and any other disease, whatever my orthopedic surgeon tells me, I follow it. But what if my orthopedic surgeon knows that along with your ortho surgery, you need physiotherapy? Along with your physiotherapy, you need a bit of exercise from your side as well. Along with your physiotherapy and exercise, you need to come for monitoring, and then I will see whether you are doing well or not. Similarly, as an endodontist, if I just look into endo and I perform endo as a pain relief, very good. I'm happy with that. But what? After pain relief, what? Pain relief, you have done a symptomatic treatment at that moment. See, I tell you something. Though I have just moved in the US for 3.5 months, but believe it or not, I've been working with the Europeans and Britishers and Australians for last 12 years. And let me tell you one more thing. It's not about the charges. See, I used to charge quite high in Malaysia, and we are charging quite high in the United States. And we were charging decent enough in India as well. It's not about the charges, what you think the patient is going to pay. And that is why I said it's about the trust the patient has in you. Now, my situation is, if I just look into the tooth as an endodontist, I'm not able to tell the patient what is needed. Patient may not agree to your treatment strategy at that same time, but what is happening, you have informed the patient once that you will need this, if you really want the long-term success. And for me, the long-term success is minimum 10 years. If I am going to do some treatment for the patient, I want that patient to come back to me after 10 years and say, yes, my tooth is surviving. And if I say 10 years surviving, that can never ever happen if you just perform a beautiful endo. If the restaurability is not good, if you have not placed a full coverage or even a beautiful, simple restoration. See, I always say this. If you do a fantastic endo, a poor restoration, the success is only 30%. If you do a fantastic endo with a beautiful restoration with nice coronal seal, the success is more than 96%. So you decide whether you want to just do what you like to do, or you want to at least inform the patient what he deserves to know. Once you tell them, then it's up to them whether they want it or not. We cannot force the patient, but at least we try to educate the patient, reinforce. It's like, I'll tell you a simple example. We have all been teachers for so many years. Students, we were the students as well. Our teachers taught us. Our teachers told us not to do this, but we kept doing that. But did they stop us telling? No, they kept reinforcing. They kept telling us, this is right, you need to follow this, you need to follow this. And ultimately what happened? We started following it. Same thing I will tell to you to inform the patient. You, whenever you meet the patient, you inform the patient the same thing again and again. 1 or 2 times he may not accept, but then he will definitely accept.
Right. So Abhishek, since you touched upon what do you call the durability or survivability of the respiration, there's Dr. Sajini was asking something similar. Is there any criteria to decide the success of treatment depending on the number of years of survival of the?
Okay, so this is a very relevant question, and I'll tell you why it is relevant, because I do carry out a lot of research as well along with my clinical practice. And before coming here, we finished a couple of research projects, which is, in fact, today morning, I was working on that paper we submitted to Australian Endodontic Journal for review. And the paper is about follow-ups. And you will be surprised to know, we did follow-up for 740 odd patients for over 10 years. You know how much was the follow-up rate? You'll be surprised to know only 14%. That is number one. Only 14% means out of 100 patients, you are able to recall the patients, only 14 patients out of that. Number one. Number two, based on the success, what we realized, we were looking into endo success. Basically, as an endodontist, I was looking into endo success. But we had the criteria in which the coronal seal was another thing, plus the periodontal healing was another parameter. Most of the failures, what we saw, out of those so many patients, most of the failures, you will be surprised, it's not because of endo. It is because of the restoration. The poor coronal seal was one of the major reasons, which has been highlighted in our endo literature for last 30 years. Nothing new. The second most reason, you know what was that? The poor oral hygiene of an individual, which is a simple thing which we think that, oh, I tell you, you put up a beautiful crown. When the patient is not able to maintain it, patient will have a subgingival or below the crown, there is going to be a caries. And patient will come back to you after a few years. So according to American Association of Endodontists guidelines and ESC guidelines, which is European Society of Endodontology, we have to have 4 years of follow-up. After 4 years only, we actually say it is actually a success or not. So minimum 4 years you have to follow up.
Perfectly said, Abhishek. And there's one more question I think we should take very quickly. If you can put in your thoughts on what Dr. Smita Datta has asked. He's asked your opinion on what is your take on the restorability or non-restorability of root submergence or a decoronation? Do you consider it as
I think if I do a deep coronation, sorry, I remove the overall coronal structure. You know who will be the most happy person here? An implantologist. Because when you're decoronating the tooth, you are maintaining the roots. But I will say there are a couple of things what you need to consider. Whether there is a periapical lesion or not. If there is a periapical lesion, even you are leaving root stump behind, you have to perform endo and seal off the coronal part, so that until patient decides that you have to go for extraction followed by implant, or patient has to go for fixed brace or resin bonded brace or a denture. But if the patient has got periapical lesion and you think you don't need to do endo and just leave it there, then I think it's going to be a no-no from my side. That means that you're leaving some infection there. In fact, that will actually affect the implant placement as well. So if the tooth is vital, no problem, you can cut it off, place a coronal seal, vitality will be no problem at all. And you can recall the patient for follow-up after 6 months or up to a year. until patient is actually deciding whether the patient has to go for an implant or not, then there should not be a problem at all. But that is only to conserve the bone structure for an implant. Then in that case, I have no problem.
Yes.
Dr. Rupesh, shall we conclude?
Yes, I think we should be concluding. That's the end of. Let me once again thank. I'm sure my friend Manuel and a lot of others would be waiting for the India-New Zealand cricket match, which is going to. And cricket, my dear friends, is probably one of the sports which is most connected to ISPRP. It's the most multidisciplinary kind of a sport. Without a wicket keeper or a bowler or a batsman, the game doesn't happen. So cricket also epitomizes what ISPRP is all about. Thank you, Abhishek, for being with you. I hand over the proceedings to Manuel.
Yeah, thank you so much, Dr. Abhishek. So I'll just conclude. I know it's 1:30 a.m. in Iowa. It's time for you to hit the bed. So Abhishek, thank you so much for your time. As Sir said, for burning the midnight oil, thank you so much for your wonderful presentation, which actually spoke a lot about our in the ISPRP. So thank you, Abhishek, and thanks a lot, Dr. Rupesh. Rupesh, sir, thank you so much for being with us. And for starting this online webinar, even though the participation is not as much as we expected, those who are here are all interested to understand this and more make use of this platform. So thank you so much, Rupesh sir. Thank you, David, again for being with us and for being one of the moderators. So I thank everyone. I thank all the participants for being here. That too, as Sir said, on a Sunday afternoon. So now a bit on the upcoming program. As I've told you, fourth Sunday, we have a program. Fourth Sunday of every month, we have a program coming up. So this is the program scheduled for November. And December, we will not be having an ISPRP online webinar because we have our undergraduate convention. So I would request again all the people to disseminate this information and be a part of the first National Undergraduate Convention. So thank you so much. Give an honest feedback. And in case you guys cannot open the link, please do not panic because we have your email IDs and we will be emailing you the certificate, the link once more. You can go through it and get your certificates. So thank you so much, everyone. So have a pleasant day and hope India wins today. So
I think that is the reason, Manuel. That is the reason no one is coming, and I think you are.
That is the reason. It's a long weekend, Abhishek. It's a long weekend here in India, and most of us, and still we had around 60 participants. That speaks that ISPRP. I mean, how this program is going on. So
yeah, and that one Sunday, it's unbelievable. I think on Sunday
because this program is basically meant for private practitioners as well because they will also benefit. So this is the time when they are free. So that is why this time has been chosen. Abhishek, so thanks a lot, everyone. Thank you so much.
Abhishek, happy Durgashtami to you and your family.
Thank you, everyone. Thank you so much. Thank you.
Yes.
Thank you, everyone.
Take care, everyone. Bye.
Bye-bye. Bye. Bye, guys.